Good afternoon, everybody. My talk today will be about the impact of using contrast mammography on the workflow and economics of breast cancer institutes. Over the past few years, we have witnessed dynamic changes in the investigation and management of breast cancer. The continuous development of new technologies in the field of breast imaging definitely brings about changes in the workflow, or in other words, it has an impact on the productivity of breast imaging units. But in the same time, it raises concerns about some economic constraints because adding these new technologies and their impact on the productivity comes on the expense of added time, added cost, and on the patient management. And actually, from this perspective, I'm going to discuss with you my experience in using contrast enhanced mammography and its impact on the productivity of breast imaging units against time, against cost, and against patient management. My lecture today is out of my experience in working in two of the most busy centers, breast imaging centers in Egypt. One of them is Bahia Breast Cancer Institute and the breast imaging unit in Cairo University Hospitals. Actually, these two units serve a lot of Egyptian women. We do a lot of cases per day. In one of these institutes, we even reach up to 300 cases per day. We perform from 45 to 50 breast contrast mammography examinations per week. And in spite of this large number of females joining these institutes, we are still concerned with providing good imaging results to these patients. I will start my lecture today discussing the contrast enhanced mammography in the perspective of productivity against time. As I told you that we serve a lot of women who join the breast imaging units in both institutes. And in spite of this large number, we are still mainly concerned with providing flawless screening and diagnostic services to our patients. Because we strongly believe that the patient convenience is the only way to reach a high compliance rate. And this could never be achieved unless we decrease the number of steps that the patient takes from the time she is diagnosed to the time that she is managed. And that's why we adjust our schedule in such a ways to allow for add-on exams to mammography and ultrasound in order to reach an accurate diagnosis in the shortest period of time. And when we think about add-on exams, we mainly think about MRI, contrast mammography, and sometimes we can even add a biopsy on the same day. And to choose between contrast mammography and MRI as an add-on exam, we must make a simple comparison between both modalities. We all know that contrast mammography is less time consuming, it is better tolerated by the patients, it's with a relatively lower cost, it is easier to interpret, and we can assess microcalcifications on the low energy image. And that's why if we think about add-on exam, we must choose contrast enhanced mammography. But we have to admit that MRI is still the gold standard of all breast imaging modalities, being multi-sequential and multi-planar imaging allows better lesion detection and characterization. We move another step and we'll discuss contrast mammography from the perspective of productivity against cost. Healthcare providers are mainly concerned with developing appropriate strategies to resolve the conflict between the demands for providing high-quality services and economic efficiency. Or in other words, they are discussing the conflict between the anticipated clinical benefit to the patients with the potential economic impact. In today's cost-conscious environment, even new imaging technologies that have the potential to improve breast cancer detection and diagnosis may become questionable if they necessitate additional investment in buying new equipment, in training radiologists, technologists, and referring physicians, in finding places to fix these new technologies, and in the material which is added to the usual technologies that we use. And looking at the equipment, actually before applying any new breast imaging modality, we have to make sure that it will really add to the old modalities in both diagnosis and management. And actually the preliminary studies that have shown comparable clinical performance for contrast mammography and MRI and a higher performance when compared to digital mammography. Yet when buying new machines, we still make our comparison based on equipment differences. Contrast mammography is actually a lower cost procedure when compared to MRI because the system cost is lower and the procedure time is shorter, but we have to admit that it is a higher cost procedure when compared to digital mammography because the system cost is higher and the procedure time is longer. And looking for training, the speed of adoption for new technologies in the field of breast imaging is likely to vary according to the ease of training and acceptance of radiologists, technicians, and above all, the referring physicians. The referring physicians must be persuaded of the potential value and improved outcomes of this technology. And from a practical experience, we can clearly declare that both oncologists and surgeons find contrast mammography easier to interpret than MRI. After an initial short resistance period to any new technology, they are now more and more dependent on contrast mammography in the preoperative diagnosis, staging, and follow-up of patients. And the statement which I commonly hear in both institutes from oncologists and surgeons is that they usually tell me, we really wonder how did we manage our patients before we had contrast mammography. And looking for the place, there is no need to set up a specific space within the radiology department to fix a contrast mammography machine, as the same mammography system can be upgraded to the contrast mammography. Other possible advantages of contrast mammography include easier access to the equipment and short waiting lists, particularly at sites and times with limited MRI availability. And lastly, for the material, the contrast material used is the well-known and relatively cheap contrast medium used in CT and IVP. Yet we have to admit that the use of contrast media comes again with an added cost, increased time of examination, and an increased risk of side effects. And now I come to the last part and the longest part of the lecture and that is the impact of contrast mammography upon productivity against patient management. As radiologists, we are asked to provide the best imaging options to our patients. And to achieve proper patient management, whenever we encounter a case with suspected breast cancer, we are asked to first look for this cancer, or in other words, detect and diagnose the cancer. And when cancer is diagnosed, we have to stage this cancer or to know how far has cancer spread. And lastly, when the patient is treated, we have to follow up this patient or determine if the treatment worked. And we'll start by having a look of contrast mammography on the detection and diagnosis. Having a general look on the breast imaging modalities, we all know that mammography was and still remains the gold standard for detection or for screening. It might be coupled with an ultrasound examination in order to yield the best outcome. When MRI was first introduced, it was thought that it will play its main role as a diagnostic modality until it was introduced also as a detection or a screening modality according to the ACR guidelines for high risk and some moderate risk individuals. And looking at this diagram, we might ask ourselves, where does contrast mammography stand? Actually, knowing that contrast mammography carries both the merits of mammography and of MRI, it should play a role in both the detection and the diagnosis of breast lesions. Looking at contrast mammography in detection or screening, we will follow the traffic lights. In general, the female population is classified into an average risk population with no specific risk for developing breast cancer, a moderate risk population who have an incidence of 15 to 20% higher than the general population to develop breast cancer, and the high risk individuals who have a risk which is 20 to 25% higher than the general population to develop breast cancer. And when coming to screening for the average risk and the moderate risk individuals, mammography screening starts at the age of 40 and it might be complemented with an ultrasound examination, while for selected moderate risk and high risk individuals, MRI is added and the examination is even performed at an earlier age. When looking at contrast mammography, I always think of contrast mammography as having a potential role to play in the screening context. Because why do a mammogram and then do an MRI where I can get the benefit of both exams in one examination? But up till now, this is not validated according to studies, and we usually use contrast mammography upon recall. Recently, an original research was published in the Radiology, and they found that the contrast-enhanced mammography was effective in screening women at an increased risk of breast cancer. This is a screening mammogram of an average risk individual. She had this nodular lesion in the left breast. It was only seen in the mediolateral oblique view. We had some concerns about this. There was a focal asymmetry just adjacent to it. On the ultrasound examination, we only saw one lesion, so we proceeded to contrast mammography to confirm these findings. This was her contrast mammogram, and actually there was only one lesion, and it was biopsied, and it turned out to be an invasive duct carcinoma. This is another screening mammogram of an average risk individual. She had this focal asymmetry in the right axillary tail. This was her ultrasound examination. There was no ultrasound correlate. There was just fibroglandular condensation underlying this lesion. Contrast mammogram was performed, and there was no contrast uptake of this lesion. And actually, this was confirmed to be an area with focal adenosis. This is another screening mammogram of a moderate risk individual. She had a mass lesion here, tiny mass lesion seen in both the CC and the MLO view on performing the contrast mammography. Yes, the lesion was faintly enhancing, but it was not only one lesion. There was another lesion in the paraareolar region. This was her complementary ultrasound examination, and this was a case of a multicentric invasive duct carcinoma. Now we move to contrast mammography in diagnosis. And a meta-analysis of contrast-enhanced mammography versus MRI was performed by Xiang et al. And they found comparable sensitivity of contrast mammography and MRI. And in the same time, contrast mammography showed a higher specificity. But for both techniques, the results were much better than for mammography. And maybe the higher sensitivity, specificity of contrast mammography as compared to MRI was because of the large false positive results of MRI, and I will show you one example. This is a 50-year-old. She's a moderate risk individual, and on her screening mammogram, she developed newly developed grouped microcalcifications. She performed both contrast mammography and MRI. On the contrast mammogram, there was no contrast uptake, while on the MRI, there was focal non-mass enhancement, which was misinterpreted as possible DCIS. Actually, a biopsy was taken, and this was a case of an atypical ductal hyperplasia. This was a false positive result for MRI and a true negative result for contrast mammography. In a study assessing the impact of using the MRI morphology descriptors in the characterization of breast lesions, we found that most enhancing lesions turned out to be malignant and most benign lesions do not show enhancement. But there is still an overlap between the enhancement of both. So we can simply classify breast lesions as non-enhancing or enhancing. The non-enhancing lesions are mostly benign, and we have a few malignant lesions which do not enhance, like the low-grade DCIS and the lobular carcinoma. But not all the lobular, some of the lobular carcinoma. And we can say the other group is the enhancing breast lesions, which is mostly malignant. And we have a few benign lesions which show enhancement. On contrast mammography, we can characterize both the non-enhancing and the enhancing lesions. We follow the mammography morphology descriptors in characterizing non-enhancing lesions, and we follow the MRI morphology descriptors in characterizing enhancing lesions. This is a simple case. She's a 48-year-old female with a palpable left breast mass lesion. In both the mammography and the contrast mammography, we can describe the shape of the lesion as rounded, the margin as speculated, and it showed a heterogeneous contrast uptake, all features pointing to a malignant pathology. This was her ultrasound examination, but we have to admit that ultrasound is essential to be performed in these cases to assess for the axillary lymph node status, because this lady, she had an amalgamated level 1 axillary lymph nodes, which is essential to be mentioned before the patient gets managed. This is another 45-year-old female with multiple palpable breast lesions. This was her mammogram. She had a retroareal, this was her contrast mammogram. She had a non-enhancing retroareal lesion, which turned out to be a fibroadenoma, and she had an enhancing mass lesion. We can describe this lesion as being oblong, non-circumscribed. It shows homogeneous enhancement, but although it carries features of a benign nature, but it is associated with pathological axillary lymph nodes. And when we magnify the lesion, we can see that the mass, we can see that there are grouped microcalcifications within the mass. A biopsy was taken and it revealed a left breast invasive duct carcinoma and an adjacent fibroadenoma. These were the lesions on the ultrasound examination. These were the pathological axillary lymph nodes. This is the malignant mass lesion, and this is the non-enhancing retroareolar fibroadenoma. This is another case. She had bilateral palpable breast masses and the right bleeding per nipple. This was her mammogram, and she had a lesion on the left side, which was mainly calcifications, and another lesion on the right side. To characterize both lesions, on the low energy image, we'll make a magnified view of both lesions. The lesion on the left is mainly microcalcifications, taking a segmental distribution, while the lesion on the right is rounded. It is encapsulated and circumscribed, and it has many lucent areas, so it is fat containing. This was the contrast mammogram of the same patient. The lesion on the right showed showed heterogeneous segmental, taking a segmental distribution, non-mass enhancement, while the lesion on the right did not show any enhancement, and a biopsy revealed a right DCIS and the left hamartoma. And because benign lesions can enhance, we have to describe them or follow again the MRI morphology descriptors when they show enhancement. We have this example of a lesion, of a mass lesion in the upper outer quadrant of the right breast, and this was the contrast mammogram of the same case. If we want to describe this lesion, we will say that it is oval in shape, it is circumscribed, and it showed dark internal septations, a feature which is typically characteristic for breast fibroadenomas. Now we've detected and we've diagnosed breast cancer, we have to move to know how far this cancer has spread or to stage this cancer. And when speaking of staging, we must mention the actual size of the breast lesions. We should mention whether these lesions are multicentric, multifocal, or bilateral. We have to mention the lymph node status and the distant metastasis. And what we can do using contrast mammography is just assessing the size of the lesions and the multiplicity, but we can never assess the lymph node status or the distant metastasis. We conducted a study in our department comparing between mammography, contrast mammography, and MRI in lesion size assessment, and we found that the sizes measured by contrast mammography and MRI strongly correlated with the post-operative pathology sizes. And both techniques gave much better results than the sono mammography. Yet looking at the results, we will find that the MRI shows a stronger correlation as in respect to the contrast mammography. And this was mainly attributed to the speculated mass lesions, because on contrast mammography, there is a tendency to underestimate the size of the speculated mass lesion. And this is a good example to show you what I mean. This is the same lesion on contrast mammography, on mammogram, and on tomosynthesis. Compare the size of the lesion on the tomosynthesis, on the normal mammogram, and on the contrast mammography, it is much smaller just because of the underestimation of the speculations. This is a 40-year-old. She had a palpable right breast mass lesion. There was an evident focal asymmetry in the right retro and paraareolar regions. To know the actual size of this lesion, it's difficult to say so, even on the ultrasound examination. While on contrast mammography, we can easily assess the size of the lesion, and it is the size, giving the surgeon the actual size of the lesion is very important so that he can follow the most suitable management protocol to the patient. This is another case. She was a 40-year-old female. She's an asymptomatic. She came for a screening mammogram where we recognized this left axillary tail nodular lesion. Striking enough, when we performed the contrast mammography, there was extensive nodular lesions infiltrating the whole breast, and this was a case of a multicentric invasive duct carcinoma. This is an example of a breast of a high-risk individual where we can point many areas of concern. Usually high-risk individuals have this type of heterogeneous dense breast parenchyma, where the actual lesion can only be seen on contrast mammography. And actually the contrast mammography showed the main lesion or the dominant lesion with diffuse infiltration of the whole of the right breast parenchyma. And this was a case of a multicentric invasive duct carcinoma. Grade 3. This female patient, she's 48-year-old. She performed left mastectomy and she had a fixed implant in the left breast. When she came for her follow-up, we noticed that she developed a nodular texture of the whole of the breast parenchyma. Doing an ultrasound, we saw many hypoechoic lesions, but to know the actual extent and what percentage of the breast is affected can only be seen on the contrast mammography. And actually, she had widespread nodular lesions involving the whole of the right breast parenchyma. This is another screening mammogram of a 44-year-old female. And this was the contrast mammography. She had the lesion in the right upper outer quadrant, mass lesion, and we suspected on the contrast mammogram that there was anterior intraductal extension. This was the MRI of the same patient. This is the mass lesion. This is the anterior intraductal extension reaching to the nipple. And MRI actually added something more to the contrast mammography, and that is her axillary lymph node status, which could not be assessed on the contrast mammography. Sometimes we use a contrast mammography to exclude multiplicity. Like in this case, she had an evident retroareolar lesion, speculated outline, which was attached to the nipple, but we had some concern about this single view asymmetry seen in the right axillary tail. Doing the contrast mammogram, only the lesion in the retroareolar region showed contrast uptake, and this was actually the only lesion in her breast. Now we come to the last step, and that is to determine if treatment worked. And the first thing in the follow-up of the patient is that we have to confirm or exclude operative bed recurrence. We have this 40-year-old female with history of right breast conservative surgery, and this is normal to see a distorted parenchyma at the site of a previous operation. But to know whether there was recurrence or no, it sometimes is even difficult on ultrasound, but with a single look on her contrast mammogram, the whole of the operative scar was studied with recurrent breast mass lesions. This is another case. She gives history of operation for an invasive lobular carcinoma of the left breast. She had subtle parenchymal distortion at the operative site, and this was her contrast mammogram, which showed also subtle contrast uptake. We had to perform an MRI to confirm our results. There was an evident enhancing speculated lesion at the operative bed. A biopsy was taken, and this was a recurrent operative bed invasive lobular carcinoma. This is another 38-year-old female with history of left mastectomy. On her annual follow-up, she developed microcalcifications within the right breast. We performed contrast mammography. It showed very subtle contrast uptake, taking a segmental distribution radiating from the nipple. This was the same, the map images of the MRI of the same patients showing the same distribution of the contrast uptake. We took a biopsy from the lesion, and actually it turned to be a low-grade DCIS, and that's why the enhancement is very subtle. But we had a benefit from the contrast mammography is that we saw the microcalcifications on the low energy image. Contrast mammography can be also used in following up patients receiving neoadjuvant chemotherapy. This is a 38-year-old female. She had a retroareolar mass lesion, and she wanted to do a conservative surgery, but the surgeons had some concern about being attached to the nipple and surrounding skin thickening. She received her neoadjuvant therapy, and this was her mammogram. It's difficult to say to what extent the lesion has responded on the normal mammogram, but looking on the contrast mammography, there is complete radiological response. This is another 38-year-old female with a triple negative breast cancer in the right breast. She had a heterogeneously enhancing mass lesion. This was her pre-chemotherapy films. This was the post-chemotherapy films, and we can see that there is complete radiological response. This is also another case. This is the pre-chemotherapy films, which she had a segmental non-mass heterogeneous enhancement with diffuse skin thickening. When we performed the post-chemotherapy ultrasound examination, we were not sure about the extent of the residual disease. The true extent is only seen on the contrast mammogram, which shows much reduction in size, but this is considered as partial response and not complete response. And then to end my lecture, definitely the mission of all radiologists working in the field of breast imaging is not only to provide the best diagnostic options to our patients, but we should do so in a timely and convenient way. This gives us a great chance to make a marked difference in the lives of those who trust our skills. Yet we have to admit that the challenge will always remain. How can we achieve this goal by using the right tools in the right time and place, while taking in consideration some economic constraints? And thank you.